Welcome back to the Doc Talk podcast. I'm Dr. Sheila Wijayasinghe.
And I'm Dr. Shazma Mathani. So today we're going to do something a little bit different. We have not talked about season 2 of the Pitt since the very first episode. We are going to focus on the finale today, but we're going to actually dig a little bit deeper into the episode, talk more about the medical cases, talk about what it got right and what we wish it went deeper on.
Yeah, this whole season, we've been chatting about it separately, Shaz, but we haven't done official podcast episodes. And we thought it would be remiss, given that we did season 1 recaps. We really wanted to sort of honor it with a season finale recap. But first, a word from our sponsor. We want to take a moment to thank Figs, our season sponsor. And honestly, this is an easy one for us because Figs are what we actually wear to work. Their scrubs are comfortable, flattering, and genuinely cute. We get compliments on them all the time from patients and colleagues, and they're also incredibly practical. The pockets actually fit what you need. Phones, notes, pens, everything. And in colder clinics and hospital hallways, the layers really do help keep you warm. Their compression socks are another staple, supportive enough for long shifts, but still really cute. Same with their hair accessories, headbands, claw clips, and scrunchies that actually stay in place on busy days.
And their work bags are so thoughtfully designed. There are multiple compartments to hold everything from my stethoscope to gear, power-up snacks, and of course my change of clothes. And if you don't work in healthcare, the Figs Lounger set is incredible. It's thick, soft, high quality. I actually just got my 3rd set myself, and I got my husband a set and he lives in it too. And so if you work in healthcare or are shopping for someone who does, Figs just makes sense. Go to wearfigs.com and use code FIGSDocTalk. That's FIGSDoctalk to get 20% off your first order. That's wearfigs.com, code FIGSDocTalk.
Okay, Saj, so I was screaming at the TV many moments during this last episode, actually throughout the whole season. And I'm so excited to talk to you about this because I want to get your insider take on a lot of the cases that we saw. So let's get into the big main case of the season finale, which is the pregnant patient who comes in with a severe headache, high blood pressure. She has had no prenatal care, what they call a free birth or a wild pregnancy. And I imagine you screamed at the TV at the same time that I did when she said, "No, please don't. I'm having a wild pregnancy."
Yeah, so this one, that set alarm bells off for me for sure. Now, this case in particular was like pretty much the only new case that we saw in this entire episode. So Sheila and I are going to do a much deeper dive into this from like a medical standpoint. Now, I have to admit the term wild pregnancy was not one that I had heard before, but it became pretty apparent what they were talking about as like the patient was talking. So this is, I guess, a wild pregnancy is one in which there is absolutely no prenatal care. So no screening, no medical care or medical intervention at all.
No doula too, actually.
And
like
even no
care.
Doula, exactly. Just like completely no one else involved. And it would, so regular prenatal care would have caught preeclampsia early. So because she is doing this wild pregnancy, that wasn't happening. And like the one line that stood out to me here, Sheila, I'm interested to hear your thoughts as well, is when they were asking kind of like, what is a wild pregnancy? And she said no to everything. And then she's like, well, women have been doing this for thousands of years. And Dr. Abbott jumps in and was like, yeah, but for thousands of those years, the infant mortality rate was 30%, right? And so I'm really, really glad that they highlighted that because there is this level of complacency and comfort that we get into. We've talked about this before in our previous episodes, which was with vaccines too, where because we have such a developed and functioning and advanced medical system that has eliminated things like vaccine preventable illnesses, that has eliminated infant mortality to a significant degree, maternal mortality to a significant degree, we forget that the times before we had all of this actually had lots of death and morbidity and mortality.
100%. So that when Abbott said that line, that there was a 30% mortality rate, it's probably higher than that actually, right? And that's where I actually said the same thing. I turned to my husband and I said, this is going to go badly. It's just because we don't have memory. We don't actually have experience, like you said. We don't have experience of measles, so we're not vaccinating against measles. We don't have experience of mothers dying in childbirth, so we're not doing a wild care. Pregnancy. So we're going to do a wild pregnancy. And these are one of those things that this is where public health really matters. This is why we message the way that we do, because there is historically such good data on things that actually work, but we don't see those things anymore. And that means that public health is working. And so I agree. And we basically saw this case unfold. And I looked at Corey and I said, high blood pressure, bad headache, she's going to have a seizure.
Absolutely. And that's exactly what we saw, right? Even from the moment she rolled into the ambulance bay, they said she has a headache. They told us her blood pressure, which was very high. So normally in pregnancy, your blood pressure should actually drop. And so she had very high blood pressure.
170 on 110, I think.
Yeah, 170, which is way too high. And then you could see that she had the pitting edema. Like those are all classic signs of preeclampsia. And so from a medical standpoint, this was very accurate. It was very well done. They brought her into a room right away, recognized that this was problematic and had the potential to deteriorate very quickly. And then the medical management of it was appropriate as well. So the first line for these patients is magnesium, as well as labetalol. That is to control the blood pressure and reduce the risk of seizures and start to kind of manage the preeclampsia. And I was happy to see that part was really well done.
Yeah, I mean, it goes really fast though, right? So you could see how quickly they were thinking of the algorithm and going through every single step. And when things were not working, they had to proceed even further. And it was like hitting this limit for them as well of like, what's next for us here in this patient who's really vulnerable in this moment. So let's do
exactly. Let's do a little teaching corner on preeclampsia and eclampsia. And so Sheila, I want to hear your thoughts about this as well. So I see this in the emergency department. I know you used to do deliveries as well. And so I want to hear your thoughts on this as well. But at its core, preeclampsia is really high blood pressure after 20 weeks of pregnancy with like some signs of end organ dysfunction as well. And so we can see changes in the kidney. And so for anyone who's been pregnant, whenever you go to your kind of prenatal visits, you give a pee sample. And the reason that you give the pee sample is because one of the first signs that you can see of developing preeclampsia, because it's a vascular disease of your blood vessels in pregnancy, is that those blood vessels can start to become leaky and to start dumping protein into your urine. And so that urine test that your doctor is looking at is to look for any signs of even small amounts of protein, because protein in the urine is not normal. And that could be a very early warning sign of preeclampsia. And then that is taken very, very seriously from a prenatal care standpoint.
Yeah, so when I'm doing prenatal care in the office, this is why we're asking you these questions. Do you have a headache? Have you noticed any vision changes? Do you have any abdominal pain that's upright upper quadrant abdominal pain? These are the red flags of preeclampsia.
Checking the blood pressure.
And we always check your blood pressure. So we always check your blood pressure, and we always actually check for edema as well. So we're looking for the swelling in your legs, and swelling can happen in pregnancy, but accompanied by these other symptoms, it can be quite serious and life-threatening, which is what happened in the sequence of events for this individuals. And really the only real cure, which is what we end up seeing, is to deliver that baby.
And you hear Dr. Abbott actually say that, right? So he talks about kind of sending the patients upstairs. It was actually the nurse, not Dr. Abbott, the obstetrical nurse that had come down and said, well, we need to get this baby out, and talked about doing a section. Like, she's 37 weeks, we'll do a section. And that's kind of, she's like, whoa, no, like no intervention. But like you said, the only cure for preeclampsia and then what progresses to eclampsia is to deliver the baby. And so what we do see, like you can kind of, stabilize, temporize, try to, use the magnesium for the seizures, use the labetalol to get the blood pressure down. But if you don't deliver that baby, it can progress into what we saw, which was eclampsia.
Yeah.
Which is when the patient starts seizing, like when the patient starts having a seizure. But then there's also this thing that they mentioned called HELLP syndrome. So Sheila, tell us about that a little bit more.
Yeah, so HELLP syndrome, and I've seen this in practice. And, Shaz, early in my career, I did obstetrics. So I did a low-risk obstetrics fellowship. When I finished family medicine, I was delivering for about 5 or 6 years. And then I retired from that because I had seen these kinds of cases. And we've talked about this before. Like, my heart is not made for this acute situations. I'm much more of a primary care brain and heart. So this is where HELLP syndrome is very scary. And I'd seen these cases a couple of times, and it was actually one of the reasons why I decided, like, this is probably not something that I can continue doing, and this is much better with people who feel really comfortable in quick situations like this. And what HELLP is that it's a acronym for hemolysis, which is a breakdown of blood vessels, and this is a whole syndrome that happens in the complex of preeclampsia, eclampsia. You can get elevated liver enzymes, which is why we ask about the belly pain. You can get low platelets, and these patients go really quickly, and there's a high risk of death when you get to HELLP. And this is where we really need to intervene very quickly. But I'd say those deliveries are really hard because of the low platelets, because of the hemolysis, they bleed really easily. They're at high risk for postpartum hemorrhage. And these are very, very sick patients.
And we kind of see that evolve as we kind of talk about the rest of this case. So that hemolysis, like that breakdown of the red blood cells, that like, so her hemoglobin was low. So it was 7, which is 70 in Canadian units. That's low. And then when you also like, so your baseline blood reserve is lower. The low platelets increase your bleeding risk. And so there's that increased risk of postpartum hemorrhage. And then what we end up seeing in terms of the progression of the case, so she develops eclampsia where she starts having a seizure. That is a medical emergency. So she starts having the seizure. They start giving her all of the right medications to treat the seizures. So they give her benzodiazepines, which are first line, even down to actually the point where they're talking about like they do decide to intubate her. And for me, the thing as an emerge doc that I really, really like here is like the teaching, right? The teaching that happens with the attending to the residents, where it's like, well, what medications would you use? And like the 2 medications that were picked were the exact medications that you should use in this situation of eclampsia. And then very quickly, the patient has a cardiac arrest. And I honestly, I hate to say that I had to laugh at this. I mean, it's not because it's a very serious case, but I feel like this is the one procedure that they haven't done yet in this show. And so of course we're going to get a resuscitative hysterotomy, or what used to be called a perimortem C-section in this episode, because like they've pretty much done every other procedure at this point. And so I'm like, yeah, I would turn to my husband. I'm like, she's going to have a cardiac arrest and they're going to have to get that baby out.
I was waiting to have this conversation with you because I wanted to ask you, like, have you ever seen this procedure done in an emergency room setting? Because I feel like you'd get that patient up to obstetrics very quickly.
So this is absolutely the one procedure that should be done in the emergency department from an obstetrical standpoint, because it is like the time is so fast. So you hear them talking about the 4-minute rule.
Yeah.
And so you aim to like from the time of cardiac arrest, so the time the mom or the patient loses pulses, you start the clock. You even heard them say like, start the clock right now. Like someone had said that and verbalized that, because every second that the mom's heart is not beating, it's not delivering blood flow, it's not delivering oxygen to the placenta and therefore to the baby. And so this resuscitative hysterotomy, the point of it is that it actually will improve the outcomes of both baby and mom. And the reason for that is that taking the baby out of that environment, because then you can start providing your own resuscitative care, like providing oxygen, improving blood flow of baby outside of the uterus. But then taking the baby outside of the uterus also decreases the pressure on the aorta and actually improves maternal circulation. That can actually save both mom and baby. And like these, so yes, I have been involved in a couple of these.
Oh, really?
The things that stood out to me here though, like where I was honestly yelling at the screen, like, where's the obstetrician here? Like and you can almost see it being set up for me as like, this is a classic oral exam case of like, you call for help, but like in an oral exam for my Royal College exam, the help is not available because they want to show, like the examiners want me to show that I know what to do. And like, this is a procedure that we learn about.
Right.
It is a procedure that we memorize inside out and backwards, because in these situations, it can be life-saving. However, in a tertiary care site,
like the one on the Pitt.
Like the one on the Pitt, they're a tertiary care site. I would even say they're a quaternary care site. They're a trauma center. So they have all the resources there. The O&G nurse comes down and says right away, well, the resident and the attending are tied up. And as soon as they said that, I'm like, she's going to have a cardiac arrest, because of course the backup isn't available. But I will tell you kind of just about a case that I had. I haven't done this myself because I work in a tertiary care center where obstetrics is available. So a few years ago, unfortunately, I had a case where a resuscitative hysterotomy was required. A mom had a cardiac arrest and she was well into her 3rd trimester. And so as soon as I knew that EMS was coming in with her, I immediately alerted my obstetrical team and my NICU team and let them know, this patient's coming in. We need you guys down here right away. We let the labor and delivery know so they can rush the cart down. We let NICU know so they can bring all their stuff down. And funny enough, not so funny, but right at the same time that this patient was coming in, we had what's called a code pink called overhead. And so that is a crashing mom.
It's a sad one to hear.
So that one is like a stat section upstairs, because something has happened where they need to they literally run down the hall for these to get the baby out upstairs really quickly. And so for me, I'm like, oh, but I need an obstetrician down here. Like, what do I do? Thankfully, at my site, we actually have 2 obstetricians covering at all times, because it's a high volume, high risk obstetrical site. But I also then was like, well, then I need a general surgeon down here. Get me the general surgery senior, because they can cut way better than I can. In the end, it was the obstetrician and the general surgery resident that performed the procedure. It is one of the fastest things I've ever seen. Boy, do they get that baby out fast. 30 seconds, Sheila. In 30 seconds, that baby is out down the hall in the other resuscitation room with NICU. And then now I only have one patient to manage and to deal with. So then all that is to say the things that stood out to me in this case that were big misses, obstetrics wasn't there. Sure, fine. They're tied up. Garcia's been around for everything. Where was she here? Like, why didn't they call someone who has surgical experience to come and help with this?
And then they also didn't, maybe, yeah.
Yeah, and they also didn't call NICU. So, like, it was that those things really stood out to me that, like, this is a tertiary care site. Like, where are those supporting services that can provide their expertise? Why are they doing this in isolation? And so this one, I have to say, has been a pet peeve of mine during this entire season, where emergency medicine, especially in a tertiary care center, we rely on our consultants and have relationships with our consultants, surgical and medical specialties that are in the emerge quite a bit, that we're calling a lot for these situations. And so this one stands out to me as like just perpetuating this unrealistic part of the storyline with the Pitt, where they don't actually highlight the fact that emergency medicine is a very team-based sport.
Okay, so you mentioned about the pediatric case as well and not calling the NICU, which is the neonatal ICU. Let's talk a little bit about that neonatal resuscitation. And so tell me what you thought about that.
So the NRP sequence, so neonatal resuscitation program, is what NRP stands for, and that's how you resuscitate a neonate, so any baby that's under 28 days old. It wasn't quite right. So like the first couple things they did, like you warm, you dry, you stimulate, so they kind of did do that. They did the APGAR scores, which are kind of a measure of how vigorous a baby is. But they kind of just use blow-by oxygen, which is not right. So in these situations, it's really actually important to bag them with positive pressure ventilation. They did not do that. So like the algorithm was just missing a few things, where they didn't actually prioritize the oxygenation and the oxygenation, ventilation, and the positive pressure piece, because that actually is unlike the order of grown-ups or adults where it's A, B, C, it's actually B first in babies, because it's typically a lack of oxygenation and a lack of breathing in neonates that is causing their heart rate to go down. And so that's what you're supposed to prioritize. And so that one really stood out for me, that like that the algorithm wasn't quite right. The focus wasn't what we're taught to do and what we know is effective in young babies, and also just the lack of NICU. Those ones stood out to me for sure.
So let's go into our next situation, which I thought was really fascinating to kind of delve into. And that was the discussion between Dr. Al-Hashimi, where it's now been revealed that she has a seizure disorder. She's been seizure-free in the past, but then she's having breakthrough seizures now. And she's coming into the position of attending, so lead of the emergency room, that Robbie's leaving behind. And they have a confrontation about this, because she trusts in him first and showing her her history to get some advice. And then sort of things start spiraling as Robbie's also spiraling to understand that he's leaving behind his emerge in the hands of somebody who he doesn't believe is capable because of this underlying medical condition, because her seizure frequency is increasing, and in an acute care center to have to lose a bit of that consciousness in that moment when you might be in the middle of a very acute procedure. He saw that as dangerous. So I'd love to hear what your take is on this, Shaz.
Yeah, so this one was a really interesting one. And I actually feel like it was, I wish that it could have been dug into a bit more, because there are a lot of like ethical implications here, right? You kind of do see Robbie like talking to the hospital lawyer when she had come down to kind of talk to him about the deposition with that measles case. And so there are ethical concerns here. And part of that is like the regulatory college. So we, in our different states in the US, different provinces here in Canada, we are accountable to a regulatory college. So for me, it's the College of Physicians and Surgeons of Alberta. And every year when I renew my license, I have to disclose whether I have anything that could impede me from providing patient care. Yeah. And because of this exact thing, like you said, Sheila, right? Like especially in an emergency department, we've seen throughout the entire first and second season how critical some of these interventions are, and how, like, if you're doing a procedure where you have something sharp in your hand, or you're doing an intubation, you have this a brief absence seizure, like that can have potentially like significant negative impacts from a patient care standpoint. And so and that's not to say that physicians don't practice with health conditions. They do so all the time. But with a seizure disorder in particular, it has to be controlled. And up until now, we learned from Dr. Al that it was controlled for well over a year, she says, right? But then now twice in one day, she's had these breakthrough seizures. And you can see that actually like has she's struggling with that one too, right? Because it's like this loss of control, I think, for her.
I see this in my own practice. I take care of a lot of physicians in my own practice. I have colleagues who have had to switch their scope of practice, basically, of what they do. If they're surgeons, for example, and they've lost the dexterity in their hand, that puts their patients at risk potentially. So they've had to make those decisions alongside our regulatory bodies to step away from the things that really they love doing. And that's what their passion is. And so I've seen that happen. It's really quite devastating. It kind of highlights a lot, like, we're human too, we're patients as well. And I thought this was a really poignant way of showing that, because clearly Dr. Al-Hashimi, like, she's still driving. And we know that with seizure disorder, you shouldn't be driving.
From your last, it should be at least 6 if not 12 months from your last seizure,
so
right?
That was really amazing.
That day.
And so that was, and I think she realized that, especially on the closing piece of the show, like she broke down in her car, realizing kind of the reality. I think the weight of that was hitting her in that moment. And I think we always have to put our patients first and safety first for our patients. But again, once things are controlled, well, generally people can still practice in the ways that they know is safe. But in this situation in particular, she's having active seizures right now.
And like, you kind of almost see like the stages of grief, so to speak, with her, right? Where she is initially quite defensive with Robbie. She says that she's gotten off phone with her neurologist and says, like, yep, it's no problem with double coverage. It's like, it's not going to be a problem. And then he confronts her about it, probably in not the most graceful way, because
this was not Robbie's most graceful.
Yeah, so we're going to talk about that next right away here. But and then you see that by the time she gets in her car, it all just comes crashing down, because I think, like you said, Sheila, she has this realization that she has lost this control. We often don't have control over our medical situations, and at a time where, like, in the emerge or in medicine in particular, like we have a lot of control in terms of like what we can provide for our patients. And then so like the contrast to that is with her and her medical condition, she doesn't have control over it. And then I think she finally in the car just realizes that probably Robbie is right in what he was saying, not in the kindest way, but that he was right.
Yeah. Let's get into that, because I think there was a lot of, I love Dr. Robbie. Like, we love Noah Wiley. His portrayal is clearly of somebody who is going through burnout. And we don't talk about this enough. And I don't know if they named it explicitly enough in this episode. But clearly this was what was infused throughout this entire shift, was that there was burnout left, right, and center happening.
Yeah. And I have to say, this, and we talked about this last night, even when we were texting about the episode, I felt like this didn't go far enough. I honestly, please don't come at me for saying this, listeners. I actually feel like they chickened out a little bit on this one, to be honest, because they had an opportunity to face such a big problem in healthcare head on. They have not shied away from any other big issues. I mean, they've had ICE, they've had immigration, they've had measles and anti-vaxxers. They have not shied away from other issues. And the one thing that has been the overarching theme of this entire shift of Robbie's mental health, they were not able to tackle it face on. And I have to say that it was a missed opportunity, in my opinion.
Yeah, I agree. And I think what's really important, Chaz, and again, we see this with our own colleagues in our own lives. We've had colleagues go through significant burnout. I've had burnout. I'm sure you've had burnout as well. That this is a very common thing in medicine. And we shouldn't be afraid to name it, because if we don't start naming it and actually addressing it, things are going to continue. And we know that 40 to 60% of physicians report some level of burnout. Suicide rates with physicians are significantly elevated. We're 2 times the general population. And across healthcare workers broadly, burnout affects about up to 50% of the workforce. So we're looking at nursing colleagues and social workers and everyone who's involved in patient care. We are at high risk of burnout.
And then if we like narrow in on emerge in particular, like we know that emerge time and time again, the data shows that it is the highest risk burnout specialty, like it like significantly above the next one. And so we often in emerge have like 40+% rates of burnout scores. Some like reporting as high as 70% even. And further reports actually suggest that at some point in their career, more than 65% of emergency physicians will report burnout at some point. And so these are high numbers. And I think that the Pitt did a really good job of like highlighting the fact that burnout is clearly an issue for frontline workers. I mean, the thing that stood out to me was that scene with Abbott and Robbie, where if like, because you can see Abbott kind of like trying to approach Robbie multiple times throughout the episode after what Dana told him the last episode, right? And then finally, after that pregnant patient that was seizing, they're in that room and he has like a full-on heart-to-heart with him to like almost like a mini intervention, I would call it, where he calls it out, he calls it for what it is, acknowledges what he has had to, like Abbott, what he has had to go through with his time serving in the military, with his PTSD, work with his psychologist, like he names all those things. But I do feel like it could have gone a bit further. Like they could have pushed this a bit further.
I agree. I loved the attempts at intervention that happened by a number of different people throughout the shift. Because clearly Robbie kept dropping hints the whole time, like, well, maybe I won't come back. Maybe this won't, like there was a lot of these little hints. He came, the first scene of episode 1 of season 2 was he was driving in on a motorcycle without his helmet on, right?
Without the helmet on.
There was so many pieces here where he's clearly hurting. And I thought it was really beautiful that a lot of different support, like characters and his colleagues were just so concerned that they did name it and they were worried. And I laughed a little bit when Abbott's like, just go on a cruise, right? Like, please just go on a cruise. On your bike. Don't go on your bike. Just go on a cruise. And I think it really highlights like how significant many of us faces. We've all had colleagues who have completed suicide, and classmates in medical school and colleagues in other parts of healthcare. And it's a really real concern. And I think if there's a concern about that happening with a colleague, it's our role to ask and check in. And it can be really uncomfortable to do that. But this is what it was modeled really nicely, that it was okay to ask and it was okay to start to chip away at where Robbie was very guarded at first. And you could see the moments of cheerfulness that happened throughout, that he really was starting to kind of hopefully see that there are people who cared for him and that there was more beyond the emergency room.
Yeah, and I do want to just take a little side note. We will put some resources in the show notes as well for any healthcare workers who are facing burnout, and put some mental health supports in the show notes for that as well. And I think, when it comes to burnout, I mean, like there's this maybe hopefully old now and outdated definition that like burnout is just being tired. It's not, right? It's like this emotional detachment. It's like feeling like you're losing yourself. And I think that, Robbie's character articulates that very, very well. Like, I don't know if I want to be here anymore. Like that's one of the lines that he uses. He talks about how, everything, even just like when he's with Abbott, I don't remember the exact words that he used, but he talked about how, nobody talks about how every human that you lose, every human that a human life that you lose, it takes a little bit of you away with it. I've said that to you before, right? Yeah. As an emerge doc. And I'm really glad, like that is a part that they did really, really well, of being able to articulate the emotional toll of seeing these awful, horrendous, just devastating cases, and what the impact of that is on you as another human, right? Because these are humans. These are our co-humans that we are treating and trying to save and fix. And it doesn't always go the way we want it to.
No. And I think we saw it with Robbie, certainly, and that was really the focus. But we also saw it with younger colleagues and learners. So Robbie was there, but also Mel King was having the deposition, and so she was having to deal with that, and that was causing significant distress. Santos was pretty burnt out in this episode, dealing with the workload and the paperwork, and her personal relationship stuff was also, we're all human in this. And Javadi also hit this wall, and so did Mohan, right? Yes. So this is where every character was just stretched to their limit. In this episode, and it was like cumulative, obviously, over years of practice for Robbie. And then for these younger individuals, they're starting to see that creep in as well.
Yeah, and I think that, I mean, the thing that we don't really talk about enough or name enough is that this is not an individual issue. It's not an individual resilience issue. It is a systemic issue, right? These are system challenges. And I think I'm probably gonna get a little bit of hate for this as well, because I did on TikTok when I made a video about this, but like Joy leaving on time, I applaud her for that. Like a couple episodes when she left on time, like we as healthcare workers we have these unreasonable expectations on us, not only by society, expectations we place on ourselves, but also by like the leaders in the system to do more, stay longer. No, we should not have to make up for the system's failings and shortcomings, because that is all at our own expense. And so all that is to say, I absolutely applaud Joy for putting up her boundaries and getting out of there and naming it and calling it.
Yeah.
She called Langdon a lunatic before she left, right?
Mean,
but like,
this is where
I'm here for it.
Yeah. I think anytime we've had a burnout seminar, it's so fascinating because a lot of it is like, well, let's meditate. Let's do this. And I'm like, how about we fix the system? Like, that's actually what will help healthcare workers, is to exactly what you're saying, Shaz. Like, it's not an individual responsibility. It's a collective responsibility. It's a systemic responsibility to ensure that we have appropriate staffing, support, time, and being able to go home and to actually have these moments to be able to have these conversations. Like, I love the debriefing moments that were displayed throughout the season, but like, it's heavy work. And so it needs to be acknowledged.
It is. And I will just make one little reference as well to like a previous episode of like the donuts that were sent down by management, right? Like, that is the exact, I mean, that happens in real
Free
life.
pizza,
That was
lunch,
not a
and
joke.
donuts.
Free
Very
pizza, lunch,
much.
and donuts. Like, come on, you guys. So like, I do like how they shone light on those things, because those are very real.
I do think, though, that like the medical student leaving early was very interesting, because generationally there is a difference in how like my learners are much better at setting a boundary than we were, and we are. And so it's interesting. I'm curious to see what's coming in the next little while, because there is a difference in how this generation is going to interact with some of those things in boundary setting.
I think most of my colleagues don't agree with me, but I think they're onto something. Truly, I do. I like I said, I fully support Joy in leaving and setting boundaries.
Yeah. So we talked about Joy very briefly, who I actually went from being kind of like a very like subtle character, and I really liked her by the end of the season.
Yeah.
Let's get into a little bit very briefly before we close here about the characters, because that's really what brings us back to watch this show, is like the realness of each of these characters, because we all know one of these characters in our life and in our careers. So let's start with Robbie.
Yeah, we talked a little bit about like the burnout piece. I feel like his arc still feels unresolved. He's still carrying everything. I actually think so that end scene with baby Jane Doe, I think it was healing. It was healing for him in some way. I actually think that the things that he was saying to her was insight in the thing and things that he was saying to himself, right? The words that he used were, everything's going to be okay. You have so many things to look forward to. You have so many things that are going to make you happy in your life. You have your whole life ahead of you. I think those were things that he was saying to himself. And so there was like a little bit of resolution, sort of. I think it certainly leaves things up in the air. Some of the things that I've seen floating around on social media, and I know that Noah Wiley has been interviewed about this as well, is that they are setting the stage for season 3 being much more focused on mental health. Have you seen those things too?
I haven't yet. No.
Yeah.
I kind of stayed off of it because I didn't want any spoilers, and then I wanted to watch it and kind of be immersed in it. But I imagine that would be a really great next step. Like, I was really hoping that, because even the psychiatrist who was in the emergency department said, please call me. I was hoping that would be the ending that we would see. But I agree with you. It was very beautiful how he was speaking to baby Jane Doe. And it was interesting because right before that moment, he had been speaking to Mohan, and she kind of said, is it too late to have the wishes that, because he expressed that, I thought I'd be married, I'd have kids, I'd have a pond that we could play hockey on. And she sort of looked at him and just like, is it too late? And then him speaking to the baby was really kind of this sweet moment of, maybe it's not.
Yeah, I had a few followers asking if they thought that he was gonna like adopt her.
I was wondering that too.
Foster care, but I will say, okay, like he is in no mentals. He would not be fit to adopt a child right now.
Right.
But it's certainly a nice little foreshadowing.
Yeah. Let's talk about Whitaker, because his character from season 1 to this season is like he's a different person.
Absolutely.
Also a bit of boundary issues.
Yeah, so this was brought up throughout the season. Like Santos identifies it, talks to Robbie about it. Robbie tries to address it with him. And then we don't see it until this episode, how entrenched he is in the lives of this young baby and the widow, right? And the farm widow.
So for anybody who didn't know what the story is, like last season, there was a case where a patient passed away from significant burns and was married to this individual who's pregnant. And then now Whitaker has been living basically at the farmhouse on the weekends and helping out with the baby and other things. And so there's a bit of a boundary. There is a boundary cross there.
It is absolutely a boundary crossing. So like, for me, that's not subtle. Robbie has named it as such. Like he did kind of, when I think it was when him and Santos were talking earlier in the season, like it was identified as a potential boundary issue. And so I don't know, it's going to be interesting to see if they do anything with that in season 3.
Yeah, I'm not sure. I just really like his arc, though. Like, I feel like he went from the intern who was being peed on and vomited on and had to change his scrubs several times in one episode to really standing up for himself. Like, he stood up for himself in front of Langdon. He basically just has become a very strong, confident character, and clinically he's doing very well too. And so it's just really nice to see that part. And yes, the other piece, but it's also interesting because I felt like when Robbie looked at him getting into the van with the baby, there was almost like a little moment of like, because Whitaker has this life outside of medicine. Yeah. He has what he wants. And that may be helping him to cope with the day-to-day of the emergency room. So there was almost like a little bit of envy in Robbie's eyes. I saw that. I was like, oh, Whitaker's got something figured out there. Although, again, boundary cross.
So let's move on to Mohan. So we know it's not a secret that Supriya Ganesh, the actress, is not returning for season 3.
Yeah.
And so we kind of saw that like she's been struggling throughout the entire season with like what's she going to do after her residency, what's she going to do for fellowship, and then it sounds like they're actually going to transition her out of the show. What are your thoughts?
Yeah, I really like her character. I think she's such a heartfelt clinician. She really delves in. She takes her time with patients. There was a couple of misses this season, and she was dealing with a lot in her own personal life at the same time, which also really resonates. Like, again, all of us are human. We all have things like family members calling us and other sorts of things that can be disruptive. And so she acknowledged that at the end, but I felt like she was so defeated at the end of the show that this was like, this is not what I'm going to be doing. And there's a lot of sadness and there's grief there too around that. But I really like her character. So I'm hopeful that she'll find something better for herself as a character. But I thought she was a lovely character to watch. Tell me about Javadi. Your thoughts on Javadi.
Listen, I just want to know what's on her TikTok, okay?
I know.
Shabana, if you're listening, like make a TikTok that is Javadi centered, because I have to say, or HBO, if you're listening, like this is like, we got little flavors of it. We found out that it's very mental health and self-care focused. And that's how like she has this eureka moment with Whitaker, right? Where it's like, oh, well, she decides that she wants to do emergency psychiatry, which totally makes sense. I can certainly identify from like someone who's like a medical content creator on social media. But I loved her character arc. It was like from season 1 of being this like very timid, like
she fainted when she
fainted. She's young, right? She's this prodigy child who's young, who like finished med school really early. She's not even 21 yet. And she's already kind of into her 4th year of medical school. And she went from being uncertain and not very confident to, by the end of this season, like being very confident in what is going to work for her and what she wants to do.
Yeah, it was a good evolution for her too. And being able to like figure out. And there's a moment, and I remember that moment for myself too, when I knew exactly what I wanted to do.
Yeah.
I was in a moment and somebody just said to me, like, you're really happy in family medicine. And I sort of looked at that person and like gave them a hug, just like Javadi gave. And it was this moment where I was like, I wanted to be a family doctor. And I had wanted to do everything else, like pediatrics and community medicine. And it just hit. And I love that she had that moment where she knew exactly what she wanted and it felt like aligned with her dreams. So let's finish with Mel and Santos, because that was a fun, like the final karaoke scene, like 2 characters that are not meant to be singing karaoke together, singing karaoke, literally letting their hair down with Mel, like her hair coming out of her braid. It was wonderful.
It was wonderful. So if you didn't watch past the credits, like go back and watch because you missed this karaoke scene. So they talk about it when they're still in the hospital, and then they actually show the karaoke scene like after a first few seconds of the credits. This one was just so lovely because you see that Dr. Mel or Dr. King is grieving the loss of this primary relationship for her, which is with Becca, her sister. Santos is equally grieving the loss of like this roommate situation with Whitaker, where like they clearly she doesn't want to say she misses him, but she does. And then they find companionship in each other in just such this awesome, fun way. I loved it. I like they're like two unlikely people to get together, but I love it.
It was so good. So tell me, Shaz, like, what is your take on season 2 versus season 1?
Very different in terms of like the tone of, I went from like really feeling like I identified, with Robbie as like, so, you know, when people ask me like, well, who's the character that you're most like? Season 1, it would have been Robbie for sure, to a very different Robbie, in season 2 with a much darker tone. And I have to say that as much as there were issues that were dealt with in season 1, I really, really like how in general throughout the entire season, the Pitt did not shy away from taking on just head first straight into some very potentially polarizing but really, really important issues in healthcare. I mean, they talked about the lack of medical insurance and what that does with Orlando. Yeah. They talked, ICE came in and what the impacts of that is. They talked about like immigration and deportation. There were, misinformation. Like that was all just faced head on. And I love how they have been able to highlight this for hundreds of millions of people.
Yeah, I don't think it was as dramatic as the last season, right? Because there wasn't as many of the really acute, scary situations like with the Pitt Fest shooting that happened last. That really was a big, like, dominated 4 episodes of last season. I thought this season was much more like a routine kind of day with routine cases, but then they really hit the social parts of medicine very, very well. And
which are such a big part of medicine.
Such a big part of medicine. Like, we can't ignore that not being able to afford your medication is a significant reason why our patients return to care or get sicker. In Canada, we think that we're immune to that, but it's very true here. Medication is expensive. We do not have a national pharmacare plan. And these are things that make it difficult for our patients to be able to care for themselves sometimes. And so there are a lot of these issues are certainly US-centric, but they do apply in Canada too. And so I do appreciate that they don't shy away from those things. It was a quieter finale in that it was sort of everyone was tired. It was a soft closing after a long shift. And often at the season finale, there's a big ending of most shows, and this one didn't have the big ending. But I think it was realistic.
Yeah, I agree. And season 1 didn't really have that big ending either. Like the parallel of everybody being on the roof at the end of season 2 with the parallel of being at the park at the end of season 1. It just kind of focused on the importance, I think, of our healthcare worker families. And so I love the way that they highlighted that. And I'm really excited to see what season 3 brings.
Me too. Hopefully we will see more and more closure maybe and more discussions and naming things. And I'm grateful to all of you listening for tuning in. We haven't done this for this season, and we just thought we'd be remiss if we didn't address it, because this is, again, one of our favorite shows to break down. And Shaz, thank you so much for breaking down all of the backstories and the real life medicine that happens in emergency rooms. Emergency room clinicians and healthcare workers are my heroes, because the work that you do is incredibly difficult and you're with people at the hardest moments of their life. And so thank you for all of that.
Yeah. And thanks for being here with me to give all the community perspective as well, because it's so valuable from an Emerge perspective too. So thanks, everybody.
Thanks, everybody.
A reminder that the Doc Talk podcast is for general information purposes only. This podcast is not intended to replace medical advice from your doctor. While we are doctors, we are not your doctor. Always speak to your own healthcare provider for questions related to your personal health needs.